So this kind of falls in with our therapeutic level monitoring. So in this question, if the patient has a therapeutic drug level and no antibodies, what would you advise? And of course, they've already gone through the work of that Dr. Vallejos wanted no infection, no strictures, nothing. You got that drug level, that you have your antibody levels, and your options are as follows. Dr. Lee, which one would you pick?
I wrote the question.
He told me to ask him this question. This is the only answer he has.
And I was just about to say, it seems to be a bad question.
Hence why I picked on him.
I guess I would ask Niels one thing before I answer your question is, so you had mentioned there's transient antibodies. And my take on this now is a single therapeutic drug monitoring episode is not the ideal way to use these, meaning this patient's flaring week 6, I get a drug level, and then you have antibodies. A lot of people, and very low drug levels, a lot of people say, oh, we're done, we're moving on. But it seems like serially, if we could, and if we could afford it, and it would be paid for, that's the way to really look at these antibody patients is, are they transient? Are they affecting drug level? Are they permanent? And are they affecting drug level? Is that what your take is? Or you think a one-time drug level and antibody level is reasonable?
So for the anti-drug antibodies, I think we don't have any predictive markers that allow us to predict whether antibodies are transient or persistent at this point in time. However, we do know that there is an association with the antibody concentration. So if antibodies are really in a high concentration, there is a low likelihood that these antibodies will be transient versus patients who have somewhat developed not specific antibodies that could be treated away and could be regarded as transient. So ideally, to rule that out, you would want to do monitoring. The second, for example, infusion, take another sample and assess the antibody concentration and especially also the drug concentration. I think it's important to focus on the drug concentration first, and if low or absent, then to look at anti-drug antibody concentration. Because just basing your decision solely on anti-drug antibody concentration, especially if it's only assessed at one time point, might not be the ideal decision.
So this phenomenon of transient antibodies, what Dr. Van Castile is describing is basically we need more data and more studies to help us understand this phenomenon really in clinical practice. Perhaps benchwork-wise we understand it, but in clinical practice it's pretty tough to be able to keep obtaining levels, for example, and costly as well. So absolutely, what he's referring to as far as very high antibodies or not so high, my approach of course, based on some of the assays that are being utilized, but when we say very high, triple digits, quadruple digits of antibody levels, somewhat high would be double digits or single digits in the antibody level, detectable levels. And so that's maybe your shortcut way of determining how high are antibodies and utilizing the algorithms that were described on the prior discussions and presentations in a sense of if it's slightly high and a subtherapeutic level, perhaps better to go ahead and escalate the dose or shorten the frequency. If triple, quadruple digits, very high, and a therapeutic level, you know now what to do as you refer to the appropriate slides. So it could definitely help us know how to best monitor our patients and treat our patients.
So now I'll answer your question. But first, I remember...
Because you got the answer already.
No, I remember why I wrote it this way, because it's an annoying question, but this comes up, right? So I agree with Fernando. It seemed like this patient is a secondary loss of responder. But I've gotten a lot of these, I'm convinced, I'm like, are they either creeped or they said I'm flaring, we've ruled everything out, and you go, okay, you have a 12 level of infliximab, and you're like, how is this possible? And that's why I wrote it this way. So I don't think we would increase the dose because we have a therapeutic level. So I think A is not correct. I'm not sure what surgery would do. This is a Crohn's patient, so I don't think surgical. They don't have a stricture, they don't have a fistula, so we're not referring them to surgery. And C and D are the two tough ones, right? So I could make a clinical case in my mind. This patient responded to TNF in the beginning, I don't believe my drug level, so I'm going to switch within class. On the other side of it,
So we're calling him or this patient a secondary.
clinical secondary
Clinical
non-response.
secondary loss of response, right? So the terminology, because they responded initially and now lost the response is what we're thinking.
But if I were as smart and black and white as my Leuven friend, I would say, no, that's an objective marker. You don't know why they went into remission the first 2 years. Could have been the azathioprine, right? They were on combination therapy. You have therapeutic drug level, you should switch out. And I think the majority of us would choose D.
Do you agree?
I think there's a third option, that,
Oh.
that you change the natural history of the disease, potentially.
How do we do that?
Go back.
Well, potentially this patient has been treated on anti-TNF for quite some time and is currently flaring. So you might have a shunt of the TNF pathway, and there are other inflammatory pathways that are, let's say, important in this patient. And I think it's not an unreasonable thought, because there are other, let's say, good options available, to first go to one of those other options, because let's say you have an objective marker that potentially you're failing a drug class more than one particular agent.
So you're suggesting a different mechanism of action, perhaps because in this setting we've already appropriately treated them with one MOA, mechanism of action. They've responded, but as we know with Crohn's disease and also with ulcerative colitis, the pathogenesis, the inflammatory cascade, this pathway is so variable, and so now you're suggesting perhaps we target a different component of this inflammatory cascade. Is that what you're referring to? Yep. Dr. Wabe?
So my question is, if you try any of the modalities that are different than TNF-alpha, and we know the response rates are good, but not 100%, and with the available options, you might struggle with, a second one beyond the first choice. My question is, would you go back if you try one modality out of class, and let's say that it did not work, would you go back to TNF-alpha at that point in time?
So changing from one MOA to another, is it too late to go back to the initial MOA? And is there any harm in that? Will they respond the same to that second, to that initial agent after walking away from it?
I mean, I think we've all done it clinically, right? So we said, oh, you're on TNF, you have therapeutic drug, we're going to go to a different MOA, which today would be vedolizumab. And then we sat around and watched them, and we said, this isn't working. And short of having a third MOA, which hopefully we'll have soon, we kind of said, well, you did respond to one TNF, so let's try another. And again, I think the big point there is no matter which one you started first, which one you started, the more biologics you've been on, they're selecting themselves as medically refractory. So the outcomes are bad. But again, short of that, what other choices do we have? And so I would say, yeah, we would recycle or cycle back through a different MOA. And thank you for Niels for pointing out, they might have gone around this pathway, right, at this point. And so maybe D is the right answer. I can't remember what I was thinking.
Dr. Vallejos, do you agree with Dr. Lee? D is the right answer?
Yeah, and I think it's. I think the issue. Oh, jeez. I'm only going to do that 100% of the time, so I apologize. Yeah, I mean, with regard to, so clearly there's enough drug level in the body. So then, if you have to assume that the drug is basically acting on the tissues, then clearly that is, it's a different pathway that's now causing the inflammation. And that's where, it's kind of the logic behind using a different mechanism of action. I think the error is not so much if you go into, for example, an anti-integrin and then went back to a TNF. And I think you could probably justify that based on, her age and, trying to avoid surgery if possible. I forgot how extensive her disease is that we can talk about. But I think probably the thing that we probably wouldn't do is if she had never really responded well to that first TNF, then I think there's no point. And then I think something that was done earlier, because again, we had not a lot of options, is a third TNF. So I think that most people, when they end up at surgery, usually at least on 2 TNFs and an anti-integrin, but probably not a good idea to try that third TNF as a Hail Mary.
Hello. The other comment I was going to make is, while this question is what would we want to do, at least in Seattle, oftentimes this decision is taken out of our hands. They go, we don't care that you have infliximab level of 50. You have to try a second TNF, and then we'll give you next MOA. So sometimes this decision is taken out of our hands, which is frustrating, but it's the world we live in.
So we're talking about payers and insurance mandating us to do one thing when really in practice we would want to do something else. Dr. Wabe?
So there's the occasional scenario too that I've seen a handful of where a patient is just not getting to any therapeutic level despite double dose and maybe decreased interval. So what's your experience on doses beyond 10 milligrams per kilogram every 4 or 6 weeks?
Dr. Van
In a patient where you're
Castile
not
should answer
achieving
this.
levels.
Are you worried about it?
Crazy doses.
But for this patient or in another
In
setting?
another scenario where despite intensified therapy, double dose, and maybe shortening the interval, you still are unable to achieve therapeutic levels, and there are no antibodies. Because I've had a handful of those.
And if that is a safety concern, that's a question.
So safety
Efficacy,
concern or any
safety,
efficacy? Yep.
Done.
I
Or
think
not?
that there is some data regarding efficacy in severe ulcerative colitis patients where that has helped giving those off-label high doses. From a
What do you mean
safety-
by high? How high did they go?
And this is just, let's say, from seeing it in data sets, but I think around 20 is what I have come across. But let's say from a safety perspective, and this is a point that was raised yesterday, was a good point. The therapeutic drug monitoring originally comes from molecules that have a narrow therapeutic range. If you go below a certain level, they are inefficacious, and if you go above a certain level, they are harmful or associated with adverse events. This is not really the case for anti-TNFs, at least, where we haven't seen an association with higher exposure and certain adverse outcomes. So from a safety standpoint, at least in that perspective, I think you're probably okay.
I mean, anecdotally, we have patients, maybe they were wearing heavy boots or something, so that their ideal body weight, right, that we've dosed them above, knowing we've gotten a level and we're like, you're close or you're low, especially those that have severe disease, right? They're metabolizing and maybe through their colon or ileum losing drug. I'm not worried. I'm not safety-wise not worried. I think efficacious-wise, I think it is worth a trial. It's just, again, payers. But according to Bill Sanborn, he's taking people with bad colitis and giving them 20 mg per kg, 20 mg per kg, 20 mg per kg. I'm not making fun of Bill because I don't want him to get mad at me. But, you know, and according to him, he was able to drive up drug levels in these people with terrible colitis with an albumin of 1. So I don't think it's unreasonable. There's no, at least I have no safety concerns. It's just, can you actually get a payer to pay for that?
Okay. And this is what's done on occasion off-label or with really heavy boots, you're able to get some additional
it's anecdotes.
dose. So anecdotal, this isn't standard of practice of what we typically would do as far as dosing of any of our biologic agents.